Welcome back. Today we are learning airway assessment tools. How to predict a difficult airway before surgery even starts. Why does this matter? It helps us prevent complications and it's required before every single surgery. There are four key tools we use: Mallampati Score, thyromental distance, neck mobility, and inter-incisional gap. Let's start with the tool 1, the Mallampati score. We simply ask the patient to open their mouth wide. This is class 1. We can see the full soft palate, uvula, pillars. This means an easy airway. This is class 2. Uvula is visible, but pillars are partially hidden. This means mild difficulty is possible. This is class 3. We can see only base of the uvula. This means difficult is likely. And this is class 4. We can only see the hard palate. This is a high difficulty risk. Here is all four classes side by side. As the class number goes up, the difficulty goes up too. Key takeaway: a higher class number always means a higher risk of difficult airway. Tool 2 is the thyromental distance. This measures the space that helps to align airway properly. We measure the distance between 2 points, the tip of the chin and the thyroid cartilage on the neck. Step 1. Place 3 fingers vertically under the chin, going down toward the neck. Step 2. Measure the exact distance using a ruler in centimeter. If the distance is more than 6.5 centimeter, that's normal range. The airway should be easy. If it's less than 6 centimeter, a difficult airway is likely. That is an important warning sign. Why does this matter? Short distance means the larynx side higher and more forward, making it harder to see. Here is the comparison. A normal distance gives us easy visualizations. A short distance make it much harder. Key takeaway: less than 6 centimeter is a red flag for a very difficult intubation. Tool 3 is the neck mobility. This checks how well the neck can move into the right position. Why does this matter? Short distance means the larynx side higher and more forward, making it harder to see. This is called the sniffing position. The neck is slightly bent and the head is tilted back. Step 1. We start with the patient head in a natural upright position. Step 2. We ask the patient to tilt their head back as far as they comfortably can. If the neck extends more than 35 degrees, that's normal mobility. Positioning should be easy. If the neck extends less than 35 degrees, that limited mobility. Positioning become much harder. Common causes of limited mobility include arthritis, the neck, previous neck surgery, or a neck braces. Here is the comparison. Normal mobility allows full extension. Limited mobility restricts the movement significantly. Key takeaway: limited neck extensions make it much harder to align the airway properly. Tool 4 is the inter-incisional gap. This simply measures how wide the patient can open their mouth. Why does this matter? A limited opening makes it harder to fit the laryngoscope blade inside. If the gap is more than 3 cm, that's normal opening. Access should be easy. If the gap is less than 3 cm, that's restricted. Access become more difficult. Here is an additional sign to watch for. Facial hair, a beard can interfere with the mask seal. Another sign is the body habituates. Extra tissues around the neck can limit positioning, and the visibility. Another sign is the protruding teeth. These can physically block the path of the laryngoscope plate. One more sign is a small or receding jaw. This reduces the space needed to move the tongue aside. So, here is the complete picture. Four main tools plus several additional signs to watch. Now, why do we combine multiple tests? Because no single test can predict a difficult airway on its own. Here is an important limitations. Each test alone has limited accuracy. Combining them improves our predictions a lot. One helpful method is called Lemon assessment. Look, evaluate Mallampati obstructions and neck mobility. Another helpful method is the 3-3-2 rule. Measure mouth opening, chin to neck space, and floor of mouth to thyroid notch. We think of this as building risk profile, moving from low risk to moderate and to high. If we find one positive finding like Mallampati class 3, that means increased cautions is needed. But if we find multiple positive findings together, that means the risk become much higher. Here is a simple red flag checklist. Mallampati class 3 or 4, short thyromental distance, limited neck extension, small mouth opening. If these red flags appears, here's what we do. Prepare the difficult airway card, get backup equipment, and inform a senior anesthesiologist. Now let's put it all together with the real case, applying everything we just learned to one patient. Meet our patient, 48 years old, here for gallbladder surgery, with a history of snoring and a short neck. Finding 1, his Mallampati scores come back as a class 3. Finding 2, his thyromental distance measure only 5.5 cm, that's short. Finding 3, his neck mobility is limited with the restricted extension. Putting these three findings together, our conclusion is clear. A difficult airway is predicted for this patient. Here is the action we take. We prepare a video laryngoscope, keep the difficult airway card at the bedside, and inform a senior anesthesiologist. Let's do a full recap. Mallampati score, thyromental distance, neck mobility, inter-incision gap. 4. Essential tool. If this video helped you, please like, subscribe, let me know in the comments which tool will you practice first. Thanks for watching the anesthesia student. See you in next lecture.